and you can see the pink color in my metrium wall. You can see.
Okay, what is the view of panelists about cutting the cervix in cases of a complete septum? The cervical part of septum needs to correction?
Many times not in it, as maybe cervical incompetence is there in later pregnancy.
Anybody has any different views?
No, sir, not necessary to cut the cervix.
Right. So, what is the, see, this is an interesting case of Robert's uterus, where you can see a laparoscopy, 2 horns, 2 tubes, but on hysteroscopy, only 1 cavity is seen. So, you have to do a blunt perforation at just near the internal os, after the internal os is opened. And you can see after cutting it, you can go into the opposite cavity and then remains the same as a complete septum. So, last case, proximal tubal block. Ma'am, I'll come to you again. So, corneal cannulation, what is the success rate? What are the indications?
Yeah, definitely corneal, if we are having a scope, we should be using cannulation. Success rate is good if it is only in the corneal end. But if it is the femora and all is involved, then cannulation will not suffice. Then you have to go into laparoscopy.
Anybody wants to have last word about the corneal cannulation?
It must be done on a dual camera, but many a times it not be so much fruitful. If it is the distal end or mid tube blockage, then many times
only for proximal tubal. Ma'am, expert comments about septum and corneal cannulation, ma'am.
Asking me?
Yes.
I'm not very much in favor of this cannulation unless the pathology is known properly, only a film sedation or maybe there was a bit of infection. Otherwise, in our country, many of them are due to tuberculosis, and unless and otherwise we treat that, only cannulation won't help in achieving pregnancy.
Thank you, ma'am.
So,
what about the septum? Few words of wisdom.
Septum, yesterday who have seen the resection of your septum need not ask any more question. So that was a perfect one. And you shown the 2 cavities first, distending each of them separately. Then you went on from the rearest end and gradually going up. First we tried with the scissors, but it was not working. So then again the knife with a bipolar knife was used and it worked very well.
I thank organizers for this opportunity. I thank my expert, Dr. Chakravarti ma'am, and all the panelists. I'm really thankful to you. Please come here for the group picture. Thank you. Thank you, ma'am. We just ran out of the time. Yeah, okay.
spread out করতে হবে। I thank the moderator, expert ma'am, and all our esteemed panelists for this very interesting and enlightening session. Moving on to the highly anticipated plenary keynote lecture session. The best teachers are those who show you where to look but don't tell you what to see. Quote unquote, Alexandra K. Treffner. On this note, I would like to begin our next session by calling our esteemed chairpersons. Our first chairperson for this session, Dr. Abhinimesh Chatterjee, sir. May we please have his CV? Sir is a consultant at Columbia Asia Hospital, Kolkata, member of AAGL USA, and has presented at FIGO 2012 and 15 and has many accreditations to his name. Our next chairperson for the session, Dr. Basudev Mukherjee, sir. Sir is a stalwart in the field of obstetrics and gynecology and needs no introduction. He is a consultant gynecologist, past president, Bengal Obstetrics Society, and has special interests in public awareness programs, menopause, and endoscopic surgery. We are truly honored to have you here with us, sir. Our next chairperson for today, Dr. Kurian Joseph. We would like to be joined by sir once he is free. I would now like to hand over the session to our esteemed chairpersons. Kushagrudi sir could not make it.
Hello.
Thank you.
Good afternoon, friends. At the outset, we, chairpersons, would like to thank the organizers to give us this opportunity to chair this important session, plenary session, where my very good friends are going to speak, and we have got 4 prolific speakers on different subjects. May we start with Dr. P.G. Paul. And I don't think he needs an introduction to this audience. Chairman, Paul's Hospital, Kochi, board member of ISGE, elected member, Society of Reproductive Surgeons, author 2 books, contributed 41 chapters, published 50 papers in international journals, invited lecture 383, I think perhaps more than that, and we have all met him in different corners of this country and outside, given hands-on training, Distinguished Alumni Award, Lifetime Endoscopy Empowerment Award, IAGE in 2018, and Achievers Award in 2023. Floor is yours, Vijay. And he will be talking on controversies in gynec endoscopy.
Thank you, sir, for the kind introduction. I have never missed any Kolkata invitations. I am really happy to accept the invitation and thank the organizers for giving me this opportunity, especially Dr. Basav, Abhinivesh, Dr. Aruna. I am speaking on some controversies in gynec endoscopy. No, there are many controversial topics. I will just cover few of the case reports, few of the cases I had come across and the way probably I have managed little differently from others. This is a case of scar ectopic. She was a 13-year-old para 2 with a live 1. She had a scar ectopic diagnosed in another country, and she had 2 suction evacuation, 1 balloon tamponade, 1 uterine artery embolization, and she had several units of transfusion. And she came back to India, and review MRI showed products of consumption, again with the persistent bleeding. So I decided for laparoscopic repair and removal of the products of consumption. This is the hysteroscopy picture. You can see the products bulging out from the scar. I just wanted to see how much products are coming out, but definitely considering her future need for a pregnancy, I planned for a laparoscopic removal. I think there was already a presentation on this. It's completely straightforward. You dissect the bladder down and identify the site of the previous scar. Sometimes I do a transillumination hysteroscopically to clearly identify the site. That will make your job easier. You completely prepare the area before a good reconstruction. So the bladder should be dissected down properly, and we just injected methylene blue, and you could see that you can see the products of consumption with the leakage of the dye. This was opened. You need a good reconstruction, so the complete product has to be removed, as well as the edges has to be clearly freshened before you actually suture. These are just stay sutures to clearly excise those areas. So I used 2 stay sutures to keep the edges everted, and used scissors to completely excise comparatively straightforward, but a good excision of this scar is important for a good reconstruction as she want to plan a pregnancy again. We normally use vasopressin. We don't use any uterine artery ligation for such cases. And it was sutured in 2 layers with the barb suture. Barb suture, the main advantage is you don't have to tighten initially so that the edges can be clearly seen and the corner should not be missed. So the tightening can be done after 2 or 3 sutures, or the first layer of suture is completed. Then you complete with the second layer for a good reinforcement. That is the end of the reconstruction. We did a hysteroscopy to check for your reconstruction. So I'm just looking at what are the recommendations to handle a cesarean ectopic. One recommendation is expectant management is not recommended at all. And transvaginal or laparoscopic or ultrasound guided aspiration or resection is the treatment of choice. Even if you give methotrexate, it should be intragestational with or without other treatment modalities, not systemic methotrexate alone. And this is endorsed by ASRM and ACOG. This is the current recommendations which I could see. And they should be definitely advised about the chance of future scar ectopic. This video I am going to show you is already shown previously, but for the completion of this controversial aspect, this is a 27-year-old, had multiple fibroids. She had myomectomy with the products of removal. 3 8-centimeter myomas were removed. And again, after 2 years, transvaginal sonography showed a thin scar with deficient myometrium. And they did a laparoscopy and they found the dye is leaking out. They performed a laparotomy, myomectomy, and defect repair. And they did an MRI which showed there is endometrial prolapse. So the myomectomy scar has become weak and the patient was advised surrogate, and she did not agree, and she was referred to me for repair of the scar. I was not very sure how to really repair this, and the initial part we did the adhesive. You can see the scar site is adherent to the rectum. As usual, for all myomectomies or this type of adhesive, I use vasopressin injection, which will give you a scissors decision with the minimal bleeding. The bowel was completely released, and you can see the uterine size actually is just less than normal size. So I marked all around for a good 2-layer reconstruction which we planned. So an incision around 1 centimeter was partially done on the myometrium, and the edges were completely excised with sharp dissection. This is deepening the outer incision I already marked out initially. The same myometrial incision done on left side, and the final scar is completely dissected out because she has 2 repair, first myomectomy, then another 2 repair, and should not work. So we planned for a 2-layer closure. Looking at the size of the uterus, I should have used a 2-0 barb suture rather than the regular 1-0 we used. Looks quite big. But anyway, we completed the repair with the same sutures. And there are only anecdotal reports of using some reinforcement over the previous scar. So we used a dual mesh, which is used by the surgeons. The dual mesh is the one they use for ventral hernia. where you have a slimy layer outside and a ethylene layer inside. This was sutured with an absorbable sutures and fixed. And this was the end product. And post-operative ultrasound after 1 month. And the myometrial thickness measured was 14 millimeter. She conceived 4 months afterwards with IVF. And this card looked. And I think 35 weeks, or Dr. Nirmala from Chennai, she had sent the patient and delivered a healthy baby. This is a scar site. We were really worried how it will look like, and you can see that there is no damage to the previous scar site. This we have published in Fertility and Sterility as a video article. This is another interesting case. A 35-year-old doctor, I did a posterior adenomyomectomy, and she insisted a mesh use, and I used a mesh, and my assistant took out the needle from her right side port. And suddenly I found the needle is seen nowhere. Even my assistant, I played the camera again. We could not see where actually the needle has lost. We searched everywhere. And we were all wondering we should do an X-ray. And we asked for the portable X-ray. And by the time the X-ray was coming, I just found my Bitoki lying on my trolley, and I thought, why not we use the hysteroscope? I connected to the gas and put it into the wound. To my surprise, the needle was very easily visible, and with a biopsy grasper, we took out the needle. This was another interesting case. I did 2 weeks back, a 30-year-old who came with amenorrhea of 1 year. She had an open myomectomy in October 21 for a fibroid of 8 into 8 centimeter, and she became amenorrheic afterwards. She was admitted with a cyclical abdominal pain and amenorrhea in September 2023, and they did a laparotomy. They did a bilateral cystectomy for endometriosis, and they opened the fundus of the hematometra of the cavity and put a dilator down and made an artificial canal, and then they put a Foley's catheter, and after 5 days the Foley's catheter came out and re-stenosed, and she had a recurrent hematometra. I was wondering how to deal with this, so I thought we will proceed. This is the ultrasound finding. The main challenge was the hematometra was almost 5 centimeter from the internal os and anteverted uterus, so you cannot really go directly with. So there's a routine cystoscopy for some symptoms. Then I did an initial hysteroscopic adhesive lysis, and after some time I found this is not going to work, I may prefer it. So I was doing under ultrasound guidance. So I passed an aspiration needle through the hysteroscopic channel under abdominal ultrasound gate, and I could not reach the hematometra. Then I put an arm pickup needle with a plastic sheath into the cavity already I created and put a transvaginal probe, and then I could get into the hematometra. This is a plastic tube of the arm pickup needle, and then I put the hysteroscope, And with the hysteroscope guidance over the needle, I used scissors and entered into the hematometer. Now you can see the chocolate coming out of the cavity. A good amount of chocolate was there. This is the cavity. To my surprise, a good, reasonably upper uterine cavity and osteo were seen. I didn't do a laparoscopy, kept ready for laparoscopy. And then I removed the lower canal synechiae. First I used a 18 French resectoscope. Then I thought I will first do a Collins knife and incise the cavity to near normal. Then I changed over and made into a cavity. I did not put any Foley's. This was another interesting case, a 35-year-old para 2 who had heavy menstrual bleeding, and they put a Marina for 6 months, completely painless, and Marina came out. So I thought, why not fix the Marina? Because she was only 35. She didn't want any other treatment. So this is the Marina. And this is an ethibond suture. I used a 3 millimeter needle, laparoscopic needle holder and held it. And alongside, I passed the Bitoki hysteroscope and push it inside under the guidance. You can see this is how it looks. This is a 2-0 ethibond suture tied onto the Marina. And you are in the cavity now. You can see the needle. With some gentle manipulation, you could really fix the suture on the posterior myometrium. This needle is, I think it's 21 needle or 18 millimeter. So you cannot really go through and through, even if you do a full thickness of this. You need a little bit of learning practice for this. And I pulled out the needle. You can see the Marina going up when I pulled through. The Marina is upside down. You have to correct it. I used, these are all hysteroscopic graspers. The main challenge was how to put the knot. I thought initially we'll put a knot pusher, but it did not really work. So instead of that, I used a regular grasper, hysteroscopic grasper, and tied a few knots. My time is out. And cut the excess suture. So now it's almost 1 year. She is doing very well. As I want to leave early, I don't showing. And to conclude, no great advance has been made in the science, politics, or religion without controversy. Controversy and debate are healthy and fundamental aspect of academic medicine and scientific progress. Thank you all for the patient attention.
Thank you so much, sir. Now I would like to request Korean Joseph sir to present the plaque to PG Paul sir, please.
Yeah, good friend of mine.
Uh, this is Professor Kurian Joseph. We have two legends of endoscopic surgery in India and the world here. Calcutta is really lucky to have them. And I think after Paul Sir's presentation, he needs a standing ovation. So many innovations he has shown today. We are just overwhelmed. Superb presentation. We are all Paul Sir's students, and we are really grateful. He has done such an innovative work here. Take our bows out. Very nice, very nice, very nice. Safe journey, sir. So we call upon our next speaker, prolific Professor Alex Addis. So we can't put our hands off new technology. So robotics is the talk of the world, and who else is the better to teach us robotics than Professor Alex? He's the Master of Medicine, PhD of Medicine, Fellow of the Royal Australian and New Zealand College of Obstetrics and Gynecology, Clinical Associate Professor, Faculty of Medicine in University of Melbourne, Senior Consultant, Royal Women's Hospital, Melbourne, Unit Director of Australian Gynecological Endoscopic Society, and Director, Agora Specialist Center. Professor Alex will be taking us through robotic surgery, which we are all looking forward to and learn from him. Over to you, Professor Alex.
Thank you very much. Can you, yeah. Thank you very much for the kind introduction. Thank you very much for the committee, for the invitation to come and speak to you. It's actually an honor to be surrounded by such great surgeons as we've seen over the last 2 days. And today I will be talking to you about the Versus, which is a new surgical robotic platform by CMR, which is the Cambridge Medical Robots Association in England. So just a quick introduction about myself. I actually grew up in Sao Paulo, in Brazil, in South America. About 25 years ago, I moved to Melbourne in Australia, and that's where I developed my medical career. So for the ones that haven't been to Melbourne, it's actually quite a pretty place to visit, and you're all invited. You'll be all my guests if you ever come. This is the University of Melbourne, where I teach. This is the Royal Women's Hospital, which is the main obstetrics and gynecology public hospital in Melbourne. And this is the Epworth Hospital, where I have my private practice, and where I also have a training center in laparoscopic surgery, and where I run the medical education. So this is the Versus robot console. It's got all the things for the surgeon, so the screen, obviously, the hand controllers to do the surgery. You've got some armrests, and then the base as well. The console is quite flexible, so it's an open console. It's hard not to make, comparisons with what we used to, which is Da Vinci and similar platforms. But instead of having your head into the console, this is actually open, and you can see how the surgeon will be wearing 3D glasses to have the 3D image. It's quite ergonomic. You can operate sitting down or standing up. The console will move up and down as needed. And that allows for better communication with the theater team, because everyone's listening to the same conversation. The next part of the robot are the bedside units, and this is very different as well. So instead of having a robotic cart with all the 4 arms that come and attach to the instruments, each one of those units controls one instrument. So this is on the left side, the robot in this storage position, so it doesn't take a lot of space. And this is the deployed arm, which is designed to sort of mimic the human arm. So they even talk about, wrist, elbow, and shoulder, similar to what the arm will do. And then the tip has this 360 rotation to move the instrument in whichever position we need to. And this is what it looks like once the instruments are attached. The hand controllers are fairly versatile. And the whole surgery is controlled with your hand, so there's no pedals. Even the electrosurgery, there is a button in there to control the electric diathermy. Then there is, the jaw, which helps you to pinch and control and open and close the instruments. And then you have a clutch button to toggle through instruments and release if you need to. And then you have those things that look like zoom in and out, and then you bring, that's how you control the camera, closer, far away, up and down, and left to right. These are the instruments, so similar to whatever laparoscopic instruments you are used to. And again, the articulation is at the tip, as you have with robotic instruments, giving you that 360 degree of mobilization. In terms of training to use the platform, the company has these online modules, which anyone can log in, and you go through 12 different modules that show you how the robot works. You learn all the different parts. You learn the terminology, you know how to control it, how to set it up. It's actually quite instructive, and you can do it at home in your own time. Then you have the simulation, like any other platform, and it's actually quite good. You learn all the exercises from simple little things, managing instruments, all the way to suturing, knot tying, and dissecting, vessel sealing, all the things that use the robot form. And they start to create that early muscle memory of moving the hand controllers and knowing what your instruments are doing. Then there is a 3-day workshop where you go through a dry lab, and also we did some cadaveric surgery and dissection. And one thing I strongly recommend is if you are implementing a new robotic platform in your hospital, take your team to train with you. So these are surgical assistant nurses, everyone that was going to be involved with the hospital, new implementation of the robot. We all trained together, and we all went through the initial cases together to keep that knowledge in, and then slowly you add new members of the team, and everyone can learn from each other. This is the robot in action, and I'll point to a few things. So you can see how the instruments are all attached to the controllers. You have the screen and the surgeon sitting on the console, and you can see it's an open console, so you're talking and everyone's sort of listening and being part of the same conversation. Then I want you to start paying attention to the screen. See how you've got the little icons at the top with their different colors. So each arm has a different color, and you can see the tip of the instrument that's attached to that instrument and that arm. So for example, on that screen you can see the green instrument has the Maryland bipolars, the orange instrument has the monopolar scissors, and there's also a grasper that's not in use at this very moment. And then using your clutch button, you can change your instrument. Any hand can control any instrument as you need. And then you can see on the arms, I've got the green instrument, the blue and the orange, and you can see which instrument is attached to each arm and which hand is controlling each instrument. The other thing I wanted to see now is how different from Da Vinci and Hugo, which have 8mm instruments, the Versus has 5mm instruments. So it's exactly the same as we are used for a normal laparoscopy. And that's why I decided on this platform, which is a lot more gynae-friendly. So this setup is exactly the same setup as I would use for a laparoscopy. 10mm port for the camera at the umbilicus, and then 3-5 instruments, which are then used for the instruments. And the other thing is, because each instrument is controlled by a separate arm, you can use as few or as many instruments as you want. So one instrument can be removed, and the assistant can use sucker or other instruments if you need to. You can use 2, you can use 3 arms, depending on what your needs are. So that's the basics of how the robot works. And I found that if you are used to one platform, a lot of the knowledge is transferable. So if you've been doing Hugo, if you've been doing Da Vinci, they will have slightly different things, slightly different terminology, but the robotic idea is very, very similar. So I've started about 18 months ago. I've done 75 procedures so far, mostly robotic hysterectomies and transabdominal cerclages, because they are sort of standard procedures which were good to get the training and get the ability going. And now I'm getting to more complex things like endometriosis, but you can do anything ovaries, tubes. Pretty much every laparoscopic procedure or robotic procedure can be done with this platform. The other good thing about the Versus is the IT component. So there's this app, Versus Connect, which is for your desktop and also for your phone. Every procedure that's done by the surgeon can be claimed and goes into this mobile app. Becomes like your little logbook as well. All your procedures will be computed in there. And then what all these procedures in this platform let you do is develop these charts to show your progress over time. So everything from setting up the robot, you can see what's happening over time, how much time I spend on the console doing the actual surgery, total surgery time from the moment that we start prepping the patient, total time in theater, including the anesthetic as well, and the number of clashes, because with those arms, you have to learn not to let them clash to each other. And you can see how there's a fair bit of variation. That's because all the procedures are included. So some difficult hysterectomies will take much longer than simple BSOs and other things. As you get more and more procedures, you have the ability to do those charts by procedure itself. So not only I can have a chart on surgery time, I can have a chart just on hysterectomies, just on endometriosis, and whatever procedure you're interested in. But you can see that mostly over time, it's a downtrend, and like everything, as you do more, you become more experienced and everything improves. Okay. So now I've got a couple of videos of the robot in action. This is a transabdominal cerclage, which actually I think will be quite topical. There was a presentation this morning about the procedure, and this is how I do it as well, and you can see the robot in action. So same thing again. You can see the camera, and I've got 3 instruments in at the same time. So pink is my monopolar scissors, blue is the Maryland bipolars, and on the orange I have the fenestrated grasper. Can you see how there's a little sphere with a line around the instrument, then tells you how rotated it is. So you can see how the instrument is it's in neutral position. As you rotate, that little ball will walk around that line showing where you are, and same thing for the camera. That camera is straight at 90 degrees looking. As you rotate, that will show you as well. So back to the procedure. I start with an incision in the utrovesical fold of the peritoneum, and then move that incision laterally onto the broad ligament to both sides. And then there's a manipulator moving the uterus from side to side. As I finish opening the broad ligament, I dissect the paravesical spaces on either side of the bladder. And once the 2 sides are done, you'll see the use of the third arm, now lifting the peritoneum from both sides, and then I can use the scissors to develop the utrovesical space. That reflects the bladder down and prepares the anterior compartment for the cerclage. Once that's done, we antivert the uterus to move to the back. And I will show you the hysterectomy, but my technique for hysterectomies, I use exactly the same steps. And most of the hysterectomies I saw this morning or yesterday, you start on the round ligaments. I'll show you how it's done slightly different. But anyway, that's now my third arm with the grasper holding the ovary. You can see that when it's not active, it will stay in the position because I'm only controlling 2. And you can see around the pink instrument, which is the monopolar scissors, how it goes from yellow to blue. If I'm using cut or coag, you toggle that on your head controllers as well. So I open those windows on the broad ligament from the posterior aspect and dissect all the way to the uterine arteries on both sides, and then I open those windows connecting the front and the back. With that preparation now, it's easy to see where the needle will go. So I'll bring the suture lateral to the cervix and medial to the uterine arteries at the level of the isthmus. So back to front on the right-hand side. And then moving to the left, front to back again, medial to the uterine vessel, so they're outside of the suture. And then I bring it posteriorly. And then what I do is I'll do that same passage again to create a double loop, which increases the strength of the suture. And I start on the right and go back to the back, so I end up with the suture at the back, and then I can tie at the back. By tying at the back, there's no suture poking into the bladder. And then tie the bow knot. You see the use of the other hand now, just the grasper controlling the knot so I don't lose the tension. Come and then tight and keep it there. And then just a few throws, and you can see how tying knots with the robot, it's so much easier than with a normal laparoscopy. It's a monofilament proline suture, so I tie, several knots. And eventually that's the procedure done. That's the end of the suture. I'll cut the sutures, and that's the cerclage done. Next procedure is a robotic hysterectomy. And you can see how I start exactly the same. So I've got a manipulator. Again, another difference I noted, I don't know if everyone does it the same, but I saw a few operations yesterday where you use a manipulator to move the uterus around, and then before the colpotomy, you get the manipulator out and put a colpotomizer. The instrument I use, and I think you've got like the Rumi manipulator, this is a reusable whole manipulator from Storz. And it's got the rod inside to move the uterus, but it's also got the colpotomizer, which is always attached at the same time. So I do the anterior dissection, so paravesical space is bladder out of the way. And this is very useful when you have previous cesarean section, adhesions. I take the bladder out at the beginning, so I don't have to worry about it in the end. When possible, if the uterus is not too large and I have access to the back, I open the same windows that I opened for the cerclage. So the advantages are, I've already identified the ureters, and the windows are open above the windows are open above the ureters, and I bring the dissection already to the uterine arteries. So by the time I start taking the pedicles, I've already taken the bladder out of the way, and I've already got the uterine arteries skeletonized. Then taking the pedicles become a very easy job. It's basically connecting all the way to the window that I've opened at the beginning. So this is just using simple bipolar and scissors, and I take each pedicle independently individually by itself. So initially the round ligament, then the fallopian tube, which I will remove at the end of the procedure, then the ovarian ligament. And as soon as I've sealed and cut all the pedicles, I just follow the dissection all the way to the windows. And you can see the uterine artery is already exposed and ready to be taken. I don't have to do any further dissection at this stage. And then same thing on the other side. Round ligament, sealed with bipolar and cut with the monopolar scissors. In this case, there was a hydrosalpinx with the tube attached to the ovary, so ovarian ligament and fallopian tube coming down together. And you can see how I'm alternating between the blue and the yellow ring on the monopolar. So that's coagulation and cut. And then you can see how having the articulation, I can bring the instrument from the other side and take the uterine artery. But that's the flexibility of the versus as well. If it's a large uterus and I need to, I can just swap the instruments. So I can get my assistant to take the bipolar from the left, move it to the right, and the other way around, and I have access to both sides, and I can use the curves as I need to. So as I said, having the manipulator still attached and the colpotomizer in there, I usually, when possible, do the posterior colpotomy first. So again, trying to do intrafascial, leaving the uterosacral ligaments attached to the vagina, but see how the colpotomizer is telling me where it is. By doing it back and then the front, all that's left now is the uterine arteries, and it's very easy to position where to get the ascending branch of the uterines, because I've added in the colpotomy to guide me where I need to go. And then finishing the colpotomy. That's the end of the hysterectomy. Uterus wasn't very large, easy to be delivered through the vagina. And then just suturing the vaginal vault, and hysterectomy is complete. So that's the end of the presentation. If I'm allowed, just a little advertising as well. This is a laparoscopic workshop that I run in Melbourne. I left some flyers outside if anyone's interested. There's no robotic surgery, it's just laparoscopy, but it's 3 days taking to all the skills and suturing and everything. So thank you very much again.
Thank you so much, sir.
Thank you,
Yeah. Sir,
Professor
please,
Alex.
just
That
one
was a fantastic eye-opener to all the endoscopic surgeons here. We really enjoyed your presentation, and many audience and like me, we are all interested in doing robotic training. And since we are aging, we want to shift from laparoscopy to robot for our own good. So how do we go about it?
Yeah, very good question. So the first thing I would say, we have to be a little bit humble. Because once you're doing laparoscopic surgery well for 15, 20 years and you're very comfortable, they give you another instrument which you're not comfortable. So it actually slows you down a little bit. The first few procedures, take longer than it would. The whole theater slows as well, because it's so easy to set up and get going with your laparoscopy. You have to get everyone learning how to dock the arms and stuff like that. So that's the first thing, have the attitude to learn. And other than that, take a few steps back, find a platform. So actually, we can't buy a robot ourselves. We need the hospitals to do it. So you need to find a hospital where you have the platform to use. And then go after your training. It's hard after you're not a resident anymore, you don't have anyone to teach and hold your hand. But it's easy, it's adult learning, we can do it. And then the company is very supportive as well. So all that initial training through the online modules, cadaveric workshops, it's available for everyone. And then the last step is if you can find a mentor. So someone who is already doing that you can tag along and get a bit of training. But it won't be different from any other surgery that you've trained. Once you get the hang of it, it's very enjoyable. So you control the image, there's no assistant moving the camera, it is always there for you. I don't know if you've noticed, but everything is always in the middle, steady, it's a 3D picture, it's 4K high quality, and you just move your hands and it's quite good. So basically, yeah, if you decide to do it, get into that path. I don't have any superpowers, and I did it, so anyone can do it.
Thank you very much, sir. Thank you. So,
Thank you so much, sir. I would now like to request Vasudha Mukherjee, sir, to please hand over the plaque to Professor Alex Adis, sir.
Committee of Endogyne 2024, it is our great pleasure and privilege to all honor Dr. Alex Adis, MD, PhD, Clinical Associate Professor, University of Melbourne, Royal Women's Hospital, Melbourne, for delivering the Endogyne 2024 keynote lecture on Saturday 10th, 2024, Kolkata. Signed by Dr. Basir Mukherjee, sir, Organizing Chairperson, Endogyne 2024, Dr. Mosumi De Banerjee, ma'am, Organizing Chairperson, Dr. Aruna Tatia, ma'am, Organizing Secretary, Dr. Joyita Chakraborty, ma'am, Organizing Secretary. May we have a huge round of applause for Dr. Alex Adis. Thank you, sir, for the wonderful session. I would now like to hand over the session to our esteemed chairpersons.
now we request one legend of endoscopic surgery in the world, Kurian Joseph, to call another legend, Prakash Trivedi, sir, on the dais.
I've been given the rather difficult job of introducing Dr. Prakash Trivedi. It's quite difficult because there are many, many pages written out there. But he's a man from Mumbai who set up the Trivedi's Total Women's Care Hospital. He's a very good organizer, a very good endoscopic surgeon, and also a very good friend. So I can't say anything bad about him. And, and he's going to talk to us slightly in one of his lesser, let's say, specialities, the urology aspect of it. You're okay, Prakash? Ready? All yours.
It's there. At the outset, it's always a great pleasure to talk at Kolkata and Bengal, because I almost feel like a state citizen of Bengal. You know, I love Bengal, I love Calcutta, and I think so. This is known for everybody here in Calcutta, and great honor to have three big giants: Kurian Joseph, B.D. Mukherjee sir, and our dynamic Dr. Chatterjee. Honor to talk for an IIG program also, and this is a very important subject, because I remember in 1983, I got a gold medal on my knowledge on female urinary incontinence. And it was V.N. Purandare sir who was the examiner. So at that time I had 126 topic between me and Rakesh Sinha, who were the batchmates. So we used to go and tell that we'll go and kill the examiner. So I owe a lot to female urinary incontinence. And I owe a lot because then I did laparoscopic birth in 1999, 10th January. Then we introduced the tape. That tape, T-suit, and now known as transobturated tape, which is the Trivedi's tape, which has got a national award. And it is the single tape which is run for 22 years. And we have done 3,500 such procedure. But my job is not about tape and this and that. My job is to make gynecologists aware and wake up that female urinary incontinence is the domain of gynec only. Because urologists find it is too small. Gynec feel, oh my God, it is difficult. After my today's talk, I can tell you from next week you will realize that in every OPD in a week you have 20 to 50 patients of female urinary incontinence. So you have to remember, when minds are like parachute, they work the best when it's open, because we have this thought process. Paul went over, I remember many years back, I was doing my T-suit and one small needle went into the bladder. I told Paul, you don't worry, there's nothing. I just took it on the side and used it. And Paul and Hafiz were telling, no, I think so, this is urologist's job. And we go and talk to urologists even about birch. To all the urologists in Jaslok and all, where do you take suture? You know, Prakash, we take it there. 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 Where? So they take one suture below, before, one suture above, one suture low down. According to Ajay Rane, the bladder neck is Sasuma. The moment your suture goes above that, you have ruined the future. So that is the knowledge of urologist. So I will be showing, I have nothing against urologists. They are my best friends, because in Bangalore we had 400 urologists where I had to show apogee, perigee, urinary incontinence, and the president told only Prakash Trivedi will operate, nobody else. So I love urologists, and I also love because they quietly see how we do uretrovesical implantation. And our teachers, they feel happy, and we pay them nicely because they are our teachers and they have to be there. So faith is knowledge within the heart beyond the reach of proof. Just now I was discussing about a patent, and give me a year. We'll have one patent which comes out on fibroid, which everybody in the world will be thrilled. So let that come out, then we'll see. It is the same like this urinary incontinence tape. I divorced the needle from the tape, and approximately, apart from 70,000 women who benefited, I also grossed 3 crores of rupees, and the cost of tape is 3,500. So basically you have to understand it is not for money, it's for the satisfaction. So you have to remember any situation can be a problem or a challenge, but I always feel that any situation, difficulty in my personality is a challenge. It is an opportunity. And my brain starts running only when there is difficulty, because in routine, I don't think so you need this. Now, this was one billionaire. She was staying in Worli. When she coughs, see where the urine will go. This was many years back. Her son in US told that there is one famous doctor in Bombay, you go and meet, and then as we were discussing and as we were Then suddenly she realized that the famous doctor she is talking is only Prakash Trivedi. And the son was to come for marriage in December. So I operated her. I told you, don't worry about the marriage. I went to the son's marriage and I was so embarrassed because in front of everybody, this is the doctor who corrected my urinary problem. No, it's not easy. No, I think as a male, unless you do a prostatectomy, it's different. But as a female actor, minister, prime minister, doctors, you name everybody, everybody will have urinary incontinence, either urge, frequency or stress. 80% will have. There is no way you can go off it. And if we will not correct, who will correct? So the problem is pretty prevalent, and you have almost 30 to 80% of women will have urinary incontinence, and very often they don't come out, because in India, if you see, only 7% consult. In my consulting room, there is a standard saying, except pregnant patient, no patient passes urine. And all patients are asked a leading question, do you have any urinary problem? Out of 10, 5 or 6 tell, oh, it is only when there is some cough or sneeze, there is some amount of urinary incontinence. Now, nobody gets sneeze continuously. And then sometimes I had a doctor from Thana, he told I have a very mild incontinence. So I just turned and I saw, she coughed and the whole urine bath I had on my face. So you have to understand what happens is, it's such a huge problem that only 16 million women have this, of which 9 million have stress incontinence, which can be corrected by a simple tape, not in all situations. 7 or 8 million and now more, because diabetes is increasing, will have urge incontinence, and that miraculous medicines have come. I have a book on, the first book on female, understanding and mastering female urinary incontinence by JP. All of you go through that. I think so your urinary incontinence practice will change. And forget about your practice changing. The women in your area will be very happy and satisfied. The prevalence in India was worked out by J.B. Sharma from AIIMS. SUI 32.16%, urge incontinence 23.7%, and 44% mixed. Now mixed is very tricky. Patient will run to you to come to fix the tape, but you have to treat the urge incontinence first and then suggest a tape. Patients will fool you, no, I have taken the medicine. So you ask the daughter-in-law whether she has taken the medicine or not. So immediately she will tell she has not taken any medicine. So basically you have to remember that urinary incontinence, whether you're talking of sphincter deficiency, you name anything. I remember once from Calcutta, after traveling 22 hours, I reached to Chennai, Raja Maheshwari's place, to demonstrate a laparoscopic birth, during that time, because not many people were doing. Even nowadays, people don't do much. But this, you have to understand, there's a lot of understanding of anatomy, muscles, ligament. So it is not just putting a stitch here and there, like the urologists always tell, there. So I always ask, there means where, it is very, very mathematical defined. So you have to know, like Sailesh, we do it in cadaveric. We inform from where the needle goes, how the needle goes. So you have to have accurate knowledge about the obturator foramen, what are the structures, why the inside-out technique was bad, because inside-out went close to the nerve, and the porosity of that tape was 70. So which allowed a microphage, and then, so in 2002, I told the company, you discontinue this product, but they discontinued in 2011 when there was an official warning. And on the next day, I had prepared our design, and which is still running. You saw a procedure yesterday. Now, incontinence, like all the thing, diabetes, you are not worried till you have. So physiology of continence is very important because it's the resting tone of bladder neck, intra-abdominal procedure of the proximal urethra, hammock-like support the posterior pubourethral ligament, intrinsic mucosal seal, and a stable, compliant, intact neuroaxis. Now this neuroaxis, I'll simplify for you, but when I had to learn, even I remember Alka Kriplani telling me, you've gone so much into detail. Unless you don't go into so much into detail, you cannot understand multiple functioning. And further to add, now we have cadaveric dissection. So the detrusor is innervated by parasympathetic. So if you want to pass urine, parasympathetic has to be stimulated. The bladder neck is other way around. It is by sympathetic. So if you want to control, the sympathetic has to be active. And the last one, as the last resort, the female can control herself, external urethral meatus, which is by somatic muscle. Now all of you will feel, this is basic. This is basic, but what happens is when we treat, we forget this basic. So M2 receptors are in the bladder, M1 to M5, M2 is specific, M3 is specific. Then in the proximal urethra, it is the sympathetic nervous system. And this sympathetic nervous system, everybody were talking about nerve sparing, nerve sparing, nerve sparing. Nobody paid an importance that S23 is the only segment from where the sympathetic fibers come. The rest straight away comes from the vagus and the upper part. So there is nothing in between about sympathetic. So that controls, and the pudendal nerve is obviously somatic. Pharmacological basis of using these drugs is very simple. Pudendal is somatic, so that is self-control. Detrusor parasympathetic, so you give M2 receptors blocker. So there were lots of M2 receptor blockers available for long period of time. Probanthine, oxybutynin, tolterodine, solifenacin, darifenacin. We all were fans about solifenacin because it was safest, darifenacin because it was more effective. But patients were not happy because they had dryness, they had constipation. So that was a very huge problem till we had the miraculous drug mirabegron, a selective beta-3 blocker. It just informs to the bladder muscle, don't act over smart. So mirabegron currently is the best medical treatment available. All that you ask to a patient, how many times you get up to pass urine in the night? She'll tell 5 times. How many times you reach the bathroom before you pass? Oh, no, before I reach, little bit starts. I told if the bathroom is closed, she will tell all starts. So it's a classical urge incontinence. Give her mirabegron 25 in the morning and 50 in the night. In 4 days, she will come to thank you. But you tell you don't come after 4 days. Take for 20 days. Take for another 20 days. And you tell it's like a thyroid. You take till as much period of time. This patient will thank you more than somebody who has wherein you have put a tape. As a duloxetamine, it's a SSNRI. To name it's a very big. Selective serotonin norepinephrine reuptake inhibitor. In simple terms, the proximal urethra is controlled by serotonin and norepinephrine. So if you take duloxetamine, which was accidentally taken, then suddenly they found that the incontinence was under control. So that is how these drugs have come. Estrogen application does nothing to your stress incontinence. It's only a little bit of OABF, it will be helpful. Why I am showing you all this thing is because all this thing is so easy that once it goes into your brain, it can never come out. Trospium, etc. is when people have painful symptoms. So solifenacin, as I told you, uroselective, less side effect, darifenacin, M3 receptor, and final master, as I told you, mirabegron. Flevoxate, when they have some continuous complaint of pain or burning. Of course, we give pyridium also. Now, this was the SSNRI. Sometimes a patient comes with urinary incontinence and she wants to wait for surgery. So you give her duloxetamine, 20 milligram or 40 milligram a day. You tell, okay, wait for 2 months, then we'll see. And we tell that after 2 months, if you'll stop, it will return. So you are giving them an opportunity to wait. When you give them an opportunity, it's like the big ant. The more you push, they will come faster. So when you tell, okay, you can come after a couple of months, then we'll put the tape. She'll come back after 3 days. Why don't you put the tape? I don't have to take medicine. But there are alternatives wherein you can withhold this. So this is how it works. The pontine micturition center, sympathetic, parasympathetic, I already explained how it works. The on of nucleus is for the pudendal. The M2 receptor that I told is parasympathetic, and proximal urethra is the sympathetic. It's very simple unless and until we complicate. So all these drugs are designed on how to act or block sympathetic and parasympathetic. Because pudendal is a cutaneous one, you cannot play with that. There are a lot of people who say that reduction of intake can improve some amount of OABF. Caffeine, smoking, avoiding aerated drinks in the later part can be useful. Weight, of course, it's useful. I'm explaining this to you because these are very simple methods. Then pelvic floor muscle. The Kegels exercise are more popular than Kegel himself. For everything, everybody does Kegel. And Kegel, people teach in so many fashion that even Kegel himself is confused that how the Kegel exercise is to be done. At the end of the day, Kegel exercise does nothing except it keeps the patient busy. So it really doesn't relieve from anything. So basically you have to remember there are a lot of other things. You have the detrusor injection of Botox in interstitial cystitis, sacral nerve modulation. I had a patient recently. Sanjay Pandey, urologist from Kokilaben, is a very thick friend of mine. We get along very well because all urologists and I get along very well because everybody has my tape in their locker. And everybody comes and attends when I'm doing a uretrovesical anastomosis, claps on behind, and I pay 60,000 to them for watching my surgery. But the important point is, even my teacher told that with your 4K and 3D, the anatomy is better than open surgery. So basically, urology started respecting gynec after our advances in handling complications of urology, and obviously, of course, handling urinary incontinence. There are many other devices which can come. Only stunt is laser. Collagen, when it is weak, which laser can generate collagen? And how do they know where to generate collagen? So all this vaginal rejuvenation, after paying 70,000 rupees, no female will tell, no, all that they have is fibrosis. They feel the change. It doesn't generate collagen. You go to UAE, 7-8 deliveries, they will now have stress incontinence. Because the pelvis are trained. Pelvic floor is trained. So they will not have urinary incontinence. So basically you have to remember. Now this is a beautiful surgery. On the right side we are showing the posterior compartment defect, which I will talk later on. Birch is very simple. You just inflate the bladder, enter from the front. The moment you entered, push it, deflate the bladder. Your Foley's bulb is there inside. Now this is the paracolpus. This is the paracolpus. So this is the Gore-Tex suture which I am taking, a single helical suture, 2 centimeter lateral and 2 centimeter below. Not there, not 3 sutures. If 3 sutures, after that, when she just stands up, she will have a run of incontinence because you have straightened the urethra. And this is creating a hammock. 16% of the birch have an enteroceal. So we do a simultaneous posterior correction. Birch used to work very well till the tapes came in. Unfortunately, the tapes were taught by representative rather than doctors. And that is where the problem started. So this is birch. It's a very good procedure. So fortunately, they took me and Raja Maheshwari to Korea. We had 10 TVTs per day, and I was very impressed. I told they must have kept for us. They told, no, it's our national program. It is done free for them. I was just telling to Raja Maheshwari, such a thick needle. I have something in my mind. So I told the company people, okay, we can easily change this design and the cost will drop down. The company people ran away. Next day, the Centennial people came. So I told, what do you do? Well, we design mesh and all. Oh, okay, very good, very good. Because the other company told, Ulf Umsten spent the entire lifetime. So I told you, entire lifetime, what is needed for designing the tape? So I sat with Centennial and I sat with a local company. I designed the needle. I designed an inert tape, polypropylene tape, which is made in US or in Europe, and it was called as T-suit. It is still the only running tape for a period of almost 22 years. The first we were using like TVT. The TVT madness was a thick needle. When I divorced the needle from the tape, the cost came down. I will not show you TVT, but also to remember, I had one patient incidentally from Calcutta by a urologist, wherein a surgery was done, and we had to remove that by 3 surgery because the person was very much scared. So we had to remove vaginally, then one port and another port. Not that I am trying to tell anything about Calcutta, but incidentally it was so. And when I used 9 cases of TVT, these are our cases. I don't want to tell my houseman did. So this was that case which I told. The 3 surgeries we did, first we removed the vaginal part which was getting rejected because high porosity. Then this was one side track which we removed, then other side track. And you can have such herniation. So I suddenly realized that there was some problem with the needle size. Again, these are my cases. This was a patient from Akola, TVT done, relaxed. 6 years later she came. I saw 2 parallel calcification in the bladder. So I told you are fine. So I went inside and I saw that the tape was going from one part to another part. She didn't have any complaints, so we just cut and removed. Similarly, this was another TVT. So I thought in 9 TVT I have 4 problems. So then I designed. This was one of the billionaire from Jew. This is the same which I was trying to tell. Ask the daughter-in-law whether she has taken the medicine. So she had diabetes, she had urge incontinence, she had burning, she had stress incontinence. So she was coming, sir, tape laga with you, tape laga with you. So I first controlled the diabetes and I told you take, at that time, darifenacin was being. So she came after 15 days. She didn't take the drug. So I told no, nothing doing. But she was telling a very typical thing. She has severe burning. So then when I put the tape, I did a cystoscopy out of 6th sense. And what you are seeing here is tuberculosis in the bladder. So what I am trying to tell is one single female, a billionaire, is having urge incontinence, frequency, stress incontinence, and cystitis due to tuberculosis. So we have to remember, you have to have complete knowledge. This is the procedure I showed yesterday, but there was a lot of Pune bombarding. Pune on one side, Pune on other side, so I didn't force too much. But this is a procedure which is over in 12 minutes. No catheterization, no cystoscopy. Saline sensor can be inject 1.5 centimeter below the external urethral meatus, and this was 2 centimeter above. Below the adductor longus tendon, you make a small 4 millimeter incision. Sensor cane is injected there only to give you a good path. If you see this surgery in Jammu, as I told you, in 3 to 10 I used to do 15 cases. So this is a small nick which is made. This is the small nick on the other side, and will pass the needle, as I have shown yesterday for people who, I think so, Hiralal saw, and these are the needles. So they are designed in such a way wherein you can enter bang vertically. This is enter bang vertically, and then angulate, and you put your finger inside and use the thumb and allow the needle tip to be felt. So you are not in the vagina, otherwise the tape will be there outside. You are not, bladder is out of question, you are in mid-urethra. So you are not too much towards the urethra, and it will come out, and it has an eye. So in the eye, you feed this tape as was seen yesterday, and then you pull it out. The same thing is done on the other side. The cost of this tape is, to me also, is 3 to 3,500. And the needle is used lifetime. You have 2 sets of needle, there is no need. The companies who made needle with a tape costing 35,000, their smart idea was you throw the needle, take another 35,000. So this is on one side, this is on the other side. The tension, because it is porosity, is well made. So you just have to have a little porosity, like people saw yesterday. What happened is the moment on cough she was leaking, we tightened a little bit more because it was under saddle block. But that is not a normal thing which is needed. This doesn't cause any reaction. This is inert. We have patients, in fact my laparoscopic birth done in 1997, even after 20 years when she came, she was absolutely fine. She had some cardiac surgery. Because of this thread, this procedure becomes very easy. Once you have put the tape in the center, the central part is a little broader. You don't have to tighten too much. You don't have to do cystoscopy. You don't have to catheterize. In 4 to 6 hours, the patient can go home. And I tell them that you are continent from today evening. If they are not continent on that day, they will not be continent subsequently. So there is nothing later. So to cover up this, we decided adjustable tape. So there were 4 thread coming in the obturator part, 4 thread coming in the vaginal part. So patient was discharged, and if she had less response, then the obturator threads were pulled, so it could tighten. If she had difficulty, the vaginal threads were pulled. Now, the big question is, what will you do with the thread? So that is an IPR right of mine. After you have done, you just pull out the thread, it will come out. So it was an adjustable tape to avoid mesh problems or tape tightening or tape loosening problem. So this was also first time design. So surgical treatment can be done with various things. People use autologous fascia, etc., etc. We have to remember that obturator tape is good. Somebody was asking, I think so, Haldar sir was asking the question that in intrinsic sphincter deficiency, the suburethral sling is better. But sometimes I have seen when the suburethral sling has not worked, I do a transobturator in her, then it works. So you have to understand that the angulation makes a difference. Then you have the urethral bulging agent. Finally, you have the artificial sphincter and all. And there are a lot of other things which are available except laser. So don't believe in laser that they will do a magic. This was Shlomo Raz. In fact, he told me with the designing of T-suit in 2002, he told me your 7th generation don't have to work. He took 10 tape, I autographed and I gave. And he told me, I will copy your design. And this is a copy of my design. So he made a mini sling. And then I told, sir, all my 7 generations are going to work because we don't work here for earning. So even if you are billionaire, they will work because we have so many millions of women. And he was very happy. He was not a company person, though from US. So basically you have to understand, ordinary man can try 1,000,000 times. But an ambitious man can try one aspect in 1,000,000 way. SUI in 1,000,000 way. Fibroid in 1,000,000 way. Fibroid research in 1,000,000 way. ICG in 1,000,000 way. Talent hits a target which no one else can hit, and genius is a target which no one else can see or can imagine. So I thank you all very much. And most important, this is election time, and I am not going to tell anything about IIG election. I am in Bengal. I am here to only tell one thing. I want Bhaskar Pal to become the president of Foxy.
Thank you, Prakash.
And I want the next president in Delhi of Foxy to be from Bengal. And Bhaskar Pal is the most deserving, like Basab, Krishnendu, and our dynamic, all these people, and I love Bengal. Thank you.
Thank you, Prakash. Friends, you have heard the teacher speaking on this subject. Give a real good, put your hands together for Prakash.
Thank you so much, Prakash Trivedi sir. Now I would like to request Abhinivesh sir to please hand over the plaque to Prakash Trivedi sir.
Thank you, Dr. Prakash Trivedi sir, for such an enlightening and wonderful lecture. The plaque which is given to Sir reads, on behalf of the members of the Organizing Committee of Endogyne 2024, it is a great pleasure and privilege to honor Dr. Prakash Trivedi, MD, DGO, FCPS, DNB, consultant gynecologist, endoscopist, ART specialist, and urogynecologist for delivering the Endogyne 2024 keynote lecture on Saturday, Feb 10, 2024. And the plaque is signed by Dr. Basha Mukherjee, Organizing Chairperson, Dr. Maushami Dei Banerjee, Organizing Chairperson, Dr. Aruna Tatia, Organizing Secretary, and Dr. Joyita Chakrabarti, Organizing Secretary. Thank you so much. Thank you so much, sir, for your wonderful lecture, sir.
Now we call upon Dr. Nutan Jain. Ma'am needs no introduction. 3 prolific persons from India has made their name in gynecology and obstetrics. One is Professor Shirodkar for the circlage. One is Pune Technique, our own Sailesh Punthembekar sir. And the other one is Jain Point. We are all proud of Dr. Nutan Jain. She needs no introduction. Author of many books from which we have all learned, and an excellent, prolific surgeon and a speaker. Proud of you, ma'am. The stage, ma'am, the stage is yours.
Thank you so much for the very kind introduction. And at the outset, I would like to thank Dr. Aruna for giving me this opportunity and calling me here. And can I get your help, please? I'm sorry, I didn't carry my laptop. And what is he trying to do from there? So it's been wonderful 2 days, excellent surgeries yesterday, and after Dr. Prakash Trivedi, Dr. Alex, and Dr. P.G. Paul, I would be just introducing my point. Can he come and help me here? Okay, just to enlarge it. So, today actually Dr. Aruna wanted me to highlight the differences between the Palmer's point and the Jain point. So all of us know that Rolf Palmer devised the Palmer's point way back in 1974. And we published, or rather documenting it from 2011, so we are just about 10 to 15 years old. Though I feel that I've been working on this since very long, and even in 2002, 2003, the workshops we used to do, we tried to show this point. So I bring greetings from my center, which recently visited by Dr. Palaskar and Dr. Barmade, and they all had good words to speak about it. So adhesions are the dreaded complications, and they carry a lot of incidents of, and even before. So this is the most dreaded part, that the overall incidence of major vascular injury is 1.1 per thousand, bowel injuries 0.7, and major vascular injuries too much, and many times the vascular injuries are lethal. So to avoid umbilicus and the adhesions in laparoscopy, there were researchers who kept moving above the umbilicus. So there was Palmer's point, all of us know the topography. Hassan abdominal entry is the most used, and it can be used anywhere. But the other 2 points, the Li Huang point moved supraumbilically, almost close to the epigastrium, 9th intercostal space. So meaning thereby that everybody thought to avoid the umbilical adhesions, we should move higher up. We thought differently, and we introduced the Jain point. And we introduced it in March 2016 with a small series. I do not remember exact numbers. Now we are very close to 10,000. So this was the dawn of a new era. So why? Because Jain point becomes quite easy to understand and to follow. So Jain point lies in the left paraumbilical region, and it is on a straight line drawn vertically 2.5 centimeters from the ASIS. So first we locate the ASIS, take 2.5 centimeter medial, then we draw a line up to the umbilicus and another horizontal line from the umbilicus. So where these 2 lines meet, that is the Jain point. And in the technique, we say that do not lift up the abdomen. We pierce perpendicularly, appreciating the layers of the abdomen layer by layer. So this is the prominent bony landmark. And what was the need? Why Jain point? And then, importantly, why left side? So, as you all see that these are the cases which we have entered with the Jain point, and the adhesions are in the midline. So, if we see that once we are moved away from the umbilicus, the vascular injury, the risk of vascular injury is totally gone. And if we compare the viscera on the left side, if you just see, that joint point is at the L4 level. Stomach comes up to T10 to L1, left kidney T12 to L3, and spleen, it's totally out of the way. Unless pathologically, if it is grossly enlarged, that's a separate issue. But there have been case reports, at least 2, where people have used the Jen point in cases of portal hypertension. So if you just see the rationale is that on the left side, the stomach, spleen, all the viscera, they lie above L4 level. And from the Jen point level, from the L4 umbilicus level, up to the pelvic brim, there's a large nascent area which is free, devoid of adhesions. So this was a case where on the right side, multiple bowel loops stuck, and if we see this area totally free. So the concept of Jen point is that this is, supposing this is a tennis field. So this is the surgical field on the patient's abdomen, upper, lower, midline, and the case I'll show you is a large incision from here to here. So these are the cases with Cox. So it acts like a referee sitting outside and monitoring the movement of the ball on either side. So as I said, it avoids the major vascular injury. We never had one, and all the people who are following. So I'll just show you the technique. So entry in previous surgery cases. So these are the cases where whenever we find, so we entered from here, but where my finger is pointing, here the bowel was making the second layer of peritoneum, totally stuck over there. So now the case I'll show you, she came to us for primary infertility, and she had 3 previous long vertical scars. One was done at the age of 7, then open laparotomy some 8 years back, and another one, there were large cystic areas and all this. So we took her up for surgery. So these were the 3 scars from top to bottom. And in this case here, if we look at the Palmer's point, again here, the bowel loop strutting from one end to the other. So here, as I said, we first will locate the NTSOP iliac spine. So that is the patient's head end. Here is the ASIS, which I will mark. I just want to show that we do not lift up the abdomen, making a vertical line at the level of the umbilicus, which is 2.5 centimeters from the ASIS. And here we put the mark. Yeah. So when we insert the Verey's needle first, we do not lift the abdomen, and we make it pass in the first pop. It is the external oblique aponeurosis. The second pop is the fused aponeurosis of internal oblique and transversalis abdomen. And lastly, the third pop is when you enter the peritoneal cavity. So here, without any lifting, totally vertical, the Verey's needle was inserted. We do the routine saline test, and we see that nothing has, the aspiration was nil, and the drop test was positive, it went in. We connect, and we see for the very initial intra-abdominal pressure. So here we see that the initial pressure itself was 0.4, and the flow rate was 1 liter per minute. So this VIIP test is quite a reliable. And now, from the same point, I'm using a reusable pyramidal triptrocar. So if I can use it in such case, you can use in any of your cases. And when I put up this case on LinkedIn, the correspondence went up to 20,000 messages across the world. Urologists, general surgeons, bariatrics, everybody jumped in. And the first one was a guy from Germany who ridiculed me. And he said, I will put up this video in the museum, never to be used. So the entire world interacted with him. And in the end, I had said, so here in this case, again, you see that the Jen point area was absolutely free. Just see, over the pelvis, how the bowel is stuck. We had no vision of the uterus, the tubes or the ovaries. So the choice of trocar, it's according to the institutional norm, your own way, but just to say that our 10,000 cases have been done totally with this wolf pyramidal tip trocar. And another feature of GenPoint is that you can use it from the right side also, the mirror image, because palmers can be used only from the left. Because of the topography of the liver, you cannot use the palmer's point from the right side. But in cases of drain sites or colon pull-through surgeries being done, or I'll cite another case here, it can be done from the right side. So this was in AGL. I was sitting having my lunch. Surgeon came and he said, you are Dr. Jain. So he cited this case, that his patient became a victim of random shootings, and she had all this multiple gunshot wounds. She remained in the ICU for long, and then after recovery, she was advised a TLH before that shootings. So that center said, now we cannot operate you because you have a long scar on the left side. So then he said that I entered by the mirror image of GenPoint, and I could do that surgery, that TLH successfully. So it avoids the upper abdominal scars and adhesions, which are a relative contraindications for palmer's point. So these are the cases which we have done with GenPoint, and we also presented it in AGL, a series of 110 cases. So I'll just show you, this is a big chevron incision. It's a hanger incision from one end to the other for amoebic liver abscess. And if I locate the palmer's point, it comes exactly here at the chevron incision. And my patient was previous to cesarean section and a large myoma. So we entered with the GenPoint, and I'll show you the picture. And we always do the drop test and the very initial intra-abdominal pressure. Now the trocar goes in, and if you just see, I'm pushing at that incision site, the liver, the stomach being pulled up, and the bowel, and now avoiding all of this, under the vision of the 5 mm, we have gone with the 10 mm port. And if you see here, I use these 4 ports. It was a big myoma. And because I usually take, I had to optimize to avoid the adhesions, so the 10 mm port was much higher up. So we are using V-lock and a 4-layer closure. So this was the port placement. So this was full hanger incision. This was also published in JMA. So other few cases were the previous surgery for septicemia. So just see again, the bowels here, when they make the second layer of peritoneum, Hassan technique will not tide over. Even you make the incision, you will go straight into the bowel. So this case, another of ectopia vesicae, there was no umbilicus, there were absolutely dense adhesions. So previous surgery for intestinal obstruction. So again, so this was the case. I'll just talk. So what are the limitations of palmer's point? So how GenPoint has come to be a savior in these locations? Everybody knows splenomegaly, large incision, large masses, even pregnancy when it is more advanced. So here in this particular case, if we see there was a big coccus incision, and at the palmer's point there were these adhesions. So whenever we have such cases, we keep documenting them. So multiple bowel loops here. So when once I was talking about this, Michal Khanis got really, he appreciated that picture in which the bowels were totally adherent over to the, making the second layer of abdomen. He's the present president of AAGL. And so there was a dilemma whenever there were contraindications of palmer's point, how to go about it. So we just published it in November in the Frontiers of Surgery, as like a journal for general surgeons. So this is the new entrant, 2011, compared to the giant published in 74. And for this, we need 2 landmarks. And if you see both of them, at least the first one is in the unsterile region. ASIS is a very prominent mark in the sterile region. And in the forward, Harry Rich wrote that out of all the landmarks, all the points, Jane's point appears to be most practical and good for day-to-day use. And then I said it has no known contraindications till now. and entry from the right side is possible. Usage in cases of infections, as I showed, and first blind port in all our cases, which I say 10,000. Now we always go with the 10 point, and it's so easy to leave it on the trainees. Any case they can enter, because in my setup I'm doing so. So it makes a good point to avoid the vessels, viscera, and adhesions. Even this up-to-date wrote a good point about Jane pointers, that compared to the Palmer's, it is lower down, so can be used as the operating port throughout the surgery, though Palmer's becomes redundant. So the main features which you can carry home is, till now, no known contraindications, a prominent bony landmark, can be used from the right side, and this the urologists are using routinely. And as we have a multi-specialty now, the general surgeons who are doing the hernia repair, they are also using Gen point. It is almost 13 centimeter lateral. So any mesh which was applied earlier, so these are the other cases of hernia repair. So now a case which has a previous mesh. So the previous mesh, the largest could be 30 centimeters. So here in this case, we had to do a TLH, and we could easily enter by the Gen point without getting entry into the trocar. So in complex gynae surgeries, as I say, nowadays we are combining TLH with a gallbladder or with a hernia, or in at least 2 cases, I've done all these 3 surgeries together. So Gen point, I make it for my port, and the general surgeon converts it into the optical port. And he uses the 10 mm optical port as the port to remove the gallbladder. So he's used in general surgery, and this was also published in Scalpel. This is a newsletter of the Association of Surgeons of India. So the minor complications which we had, as anywhere, you can overshoot or undershoot some mental emphysema, but usually if at all there are adhesions like this here, so it may bleed a little bit, but we have never had any occasion to that the blood is dripping, or you have to take a cautery, or you have to take a suture. So major complication is restricted to 1, and so this is the older data. So now it's close to 10,000. So this patient had a transverse scar in the neonatal period at the level of umbilicus for some intestinal problem. So we strongly suspected that there will be adhesions, and there wasn't appearing to be any point to enter. The MRI said no loops of bowel. So this was the scar. And in this patient, we entered the bowel, and the incision was, it was increased to 2.5 centimeters, the bowel loop taken out, and it was repaired and tucked back. The patient was discharged after 3 days. So Gen point, as very humbly I will accept that the chairpersons already acknowledged. But the last which I spoke was in SLS in the US, and it was a meeting of colorectal, onco and bariatrics, and there I got good accolades. That meant that Gen point is going to permeate beyond the gynecological arena, and it is of use for all the surgeons and other things. So recently, only 2 days back, I saw this, the FIGO book, and the earlier was pregnancy. We've got a couple of citations that Gen point is safer in pregnancy, and this was for the routine entry and in previous surgery cases. So other surgeons, like this was a one from Spain, and this was a paper very recently from Japan. And direct trocar entry has also been used by, this is a paper from Europe. And so mostly all the papers which are now coming up, and we worked hard and we published it extensively, several cases in most of the journals which are internationally done. And just at the end, I will cite another case from a very worthy colleague, an AAGL board member. So he said that he had a case who had a vertical incision from epigastrium to low down because of a previous splenic rupture, roadside accident. And when they were doing the TLH, they tried the Hassan, they tried the Palmer's, and then they could enter, I think, from the same side as the Gen point. So we keep getting accolades. Like, people feel happy and they report back. So just, it can be used as the first blind port. It is good for complex entries. and multi-specialty teams working together, used in large masses, and the lowest complication rate avoids vessel injuries. It's reproducible, and especially for the younger lot, it is easy to learn, takes away the fear of vessel, viscera, and adhesions injury. So it's a method of choice. So, but I would just say, very humbly accept that it is a gift of God. God created the left side of the pelvis, abdomen, as a nascent zone. We were just Christopher Columbus to find out that this is a nascent area. It's a gift of God, which I'm just passing on to you people. Thank you.
Really excellent presentation, ma'am. One question from the chair. Jane point is fantastic, but surgeons have gone away with the blind technique of entry. They're mostly doing open laparoscopic entry. What is your take on that?
Yeah. So my take can be, this is the question which is always asked to me, so I'm always very well prepared to answer it, that if we go by the experience and by the published data, that in all the 10,000 cases, I have not used OptiView or open Hassan technique. Secondly, we have a series of cases, 110 I published, where the bowel was making the second layer of the peritoneal wall. And if you had gone by the Hassan technique, you would have been directly into the bowel. So, as I said, everybody is using Gen point according to the institutional norms, their habit, their, how the hospital gives you the disposables. So for low settings, low economy settings, and for in my use, and all the fellows and people who are just doing, most of them are using it with a blind technique.
Thank you very much, ma'am. That was an excellent session. Now we'll go for the plaque.
Thank you so much, Nutan ma'am. Now I would like to call up on stage Aruna Tatia ma'am, and also Ashish Mukherjee sir and Ravindra sir to present the plaque to Nutan Jain ma'am. Please.
Thank you so much, Nutan Jain ma'am, for your excellent lecture. The plaque given to her will read as follows. On behalf of the members of the organizing committee of Endogyne 2024, it is our great pleasure and privilege to honor Dr. Nutan Jain, Director of Vardhaman Infertility and Endoscopy Center in Muzaffarnagar, India, for delivering the Endogyne 2024 keynote lecture on today. It is signed by Dr. Basu Mukherjee, Organizing Chairperson, and Dr. Moshumi Deb Banerjee, Organizing Chairperson, Dr. Aruna Tatia ma'am, Organizing Secretary, and Dr. Joyita Chakraborty ma'am, Organizing Secretary. Thank you so much.
Legends are not defined by their success, but by the impact they have on the lives of others. Let us join our hands and give a thundering round of applause to the legendary surgeons for gracing this occasion with their presence and for their highly informative and inspirational lectures. We are truly honored to have you with us. I would now request the August gathering to kindly move for lunch. Thank you so much.